All right, let's talk about intraoperative hypotension. If you're studying for your anesthesia exams, you've come to the right place. We're going to break this down into a clear, structured framework. Think of it as your high-yield masterclass for one of the most critical events you'll ever have to manage. So, let's just jump right in. Picture this. You're in the middle of a routine surgery, a lab chole. Everything's going smoothly. And then, suddenly, the monitor goes quiet. The blood pressure trace is just gone. You check a pulse, and it's thready and fast, maybe 120. This is it. This is that moment where all your training really counts. And let's be crystal clear, this is not just a number on a screen you need to fix. This is a full-blown anesthetic emergency. Your ability to think clearly and act fast is what stands between your patient and a major problem, because right now, their vital organs aren't getting the blood flow they need. So here's how we're going to tackle this. First, we'll talk about the stakes. Then, we'll dive into the core physiology. This is key. We'll look at how to spot patients who are at risk, how to figure out the cause, run through the crisis management drill, and finally, open up our drug toolkit. Okay, first up, Section 1. Let's really get our heads around why this is such a big deal and what's actually at stake for the person on the table. So, what's the official definition? You know, the one you need for your exams? We're talking about a mean arterial pressure, a MAP, that's dropped below 75% of the patient's usual value. The key word there is usual. It's not about some random absolute number. It's a relative drop for that specific patient. It's all about keeping their brain, their heart, and their kidneys perfused. And if you need a reminder of why this matters, this quote from the source material says it all. If it's not corrected, you're looking at ischemic changes. And what does that mean? It means things like stroke, heart attack, kidney failure, and for obstetric patients, even fetal compromise. The stakes just couldn't be any higher. Right, on to Section 2, the core physiology. Seriously, think of this as the master key. If you understand this one simple concept, you can unlock the diagnosis for pretty much any scenario they throw at you. And this is it. This is the single most important equation you need to know for this topic. Mean arterial pressure equals cardiac output times systemic vascular resistance. Every single cause of hypotension, no matter how weird or wonderful, comes down to a drop in one of these two things. That's it. If you remember nothing else, remember this. So now that we've got the physiology down, let's try to get ahead of the problem. Section 3 is all about anticipating trouble before it starts by spotting the patients who are most vulnerable during your pre-op assessment. These are the classic groups you need to have on your radar. You know, patients with other health issues like hypertension or aortic stenosis. Anyone who might be low on fluid, like from a trauma or sepsis. The elderly, because they just don't have the same physiological reserve. Obstetric patients, because of that aortocaval compression. And of course, anyone getting a spinal or an epidural. Okay, so despite your best efforts, it's happened. The blood pressure has crashed. Now it's time to put on your detective hat and think like an anesthetist. This is Section 4, systematically figuring out the cause. Now, this is really fascinating. This data comes from the Australian Incident Monitoring Study, and it gives us some huge clues about where to look first. What's the number one cause? Our own drugs, at 26% of cases. Right behind that is regional anesthesia. The takeaways here? The first place to look is always at what you, the anesthetist, have just administered. So we're going to use that master equation we just talked about to build our differential diagnosis. We can split all the possible causes into two neat categories, two main pillars. Things that reduce cardiac output and things that decrease systemic vascular resistance. So first, let's look at a drop in cardiac output. Why would that happen? Well, it could be from decreased preload. Think of a major bleed or a big pulmonary embolus. It could be that the heart's pumping action, its contractility, is weaker, often because of our anesthetic drugs, or maybe even a heart attack on the table. Or it could just be a big drop in heart rate from something like vagal stimulation. Now for that other pillar, a drop in systemic vascular resistance. This is basically widespread vasodilation. The blood vessels have gone all floppy. Again, the most common culprits are pharmacologic, our induction agents, the gases we use, or a spinal block that's gone a bit too high. Or it could be a major medical event, like anaphylaxis or overwhelming sepsis. Okay, you've got your list of possible causes running through your head. Now it's time to act. Section 5 is the crisis management protocol, the stuff you need to know by heart so you can respond instantly. This is your immediate drill. Number 1, call for help. Never, ever try to manage a crisis alone. 2, tell the surgeon to stop what they're doing.
3. Get the patient on 100% oxygen. 4. Turn down or turn off your anesthesia. 5. Do a quick ABC assessment. And 6. Get a fluid bolus in to optimize their preload. This sequence needs to be automatic like muscle memory.
The fluid is running wide open, but the pressure is still in the boots. It's time to escalate. So for our final section, we're opening up that pharmacology toolkit and picking the right drug for the right problem. Okay, this table right here, this is pure exam gold. You absolutely have to know your sympathomimetics. Is the problem mainly vasodilation? Well, then a pure alpha agonist like phenylephrine or metaraminol makes a lot of sense. Is it more of a contractility issue? Then maybe a mixed agent like ephedrine, which also hits those beta receptors, is a better choice. And in a total catastrophe, adrenaline is your friend. Knowing these drugs is just non-negotiable. So let's bring this all the way back to the beginning. Back to our patient. You've run through the drill. You've thought about the causes for this sudden collapse. Could it be a gas embolus from the laparoscopy? Anaphylaxis? A massive bleed? With everything we've just covered, which drug are you reaching for first? And more importantly, how are you going to justify that choice to your examiner? The structure and the core information for this whole explainer came directly from the anesthesia tutorial of the week, specifically number 148, which was written by Dr. Helen Bryant and Dr. Helen Brumhead and published way back in August of 2009. And I've got to say, this series by the World Federation of Societies of Anesthesiologists is just a fantastic and totally free resource for learning. I really recommend you make it a regular part of your study plan. Keep at it, and good luck with those exams.